Good. Good morning, everyone. For you today, for the speech about emergencies, today I will be talking to you. Anyways, you guys have never heard me speak before, right? I'll say that. In my country, I was brain surgeon. Here, I'm forced to be EMS physician. So, okay. Anyways, welcome to our stage. I'm sorry, I'm a little, I was disoriented here for a second because I thought I was supposed to go on at 2 o'clock, but I'm glad to take the stage. I have to turn off my phones because if they go off, it'll be not pleasant. All right, that's that. And then this one. And then this one. Okay. Okay, good. We're all set. All right. Good morning. I am for you today to do speech of this emergency. Okay. So, all right. So, first of all, I just want to say, it's not working. So that's another thing. I'll have to do this. Sorry about that. I was going to come up and prepare all this stuff ahead of time. See if I can get out of here. Turn off the Wi-Fi. It's picking up a Wi-Fi thing. Were you guys frightened when I started speaking in some Eastern European language or something like that? So, I've actually been banned from several foreign countries from using their language because of, I try to be nice and try to use their language, but apparently I butcher it so badly that they have asked me not to use it again, that kind of thing, so that's it. So today I'm going to talk about my 2020 vision for PCR management, and specifically discuss the critical role of patient care records in 2020, review the latest in ePCR, et cetera, and analyze the current PCR techniques, et cetera, okay? Current PCR products. And, okay, you all prepared? Yeah. CPR? Not PCR? Oh, okay, well, let me fix that. Okay, sorry. Hang on. I can do this. Okay. PCR. Okay, CPR? Okay, here we go. All right. So before I get started, for those of you who haven't seen this before, they want me to play it again. Those of you who have seen this before, I do it. For those of you who haven't seen it, you'll enjoy it because it's a case study that sort of sets up the rest of the talk for the day. Patient has a fractured fibula on a mild sedative and probably can go home tomorrow.
Patient has a fractured fibula, given a mild sedative, so he can be able to go home tomorrow.
Daddy's gonna be so excited.
That killed him.
All right, so don't judge too quickly. So first of all, those of you may not know this, but I have been a speaker here in the past, and what happened is that apparently there's some bylaws at OhioHealth that say for every, articulate, charismatic, attractive speaker, articulate speaker that you get, there's sort of an affirmative action that every once in a while you have to have speakers who are, let's say aesthetically challenged, okay? So when I heard that, I was like, holy cow, and I was kind of hurt, because they chose me this year to be their aesthetically challenged person. But I actually have to admit, I was in what do they call that? I was in a TV news network thing. They had this thing called wardrobe and makeup. That's what it is. And when I went in there, they immediately called for backup, okay? So there's something to it. And actually, I was in a village last year, a seaside village in Sicily, and the nice villagers tried to roll me back in the water. So it's just one of those things, might be what's going on there. So here I am. You're stuck with me, okay? But there is a new insurance policy out that says if you have to see me again, you can file a claim for damages as it goes in there. But in my defense, I was unsupervised as a child, et cetera, and so I'm blaming it on my parents. Here we go. So I was once a critical care doctor, okay, and one of the things I was working on might require blood work in the field, and I cut a deal to get the blood work done by, they said, They said, what are you going to do for us? And I go, oh, what would you like me to do for you? They said, we heard that you talk to your boss. He says, and I'd never heard this expression before. He says you think outside the box. And I go, okay. I had no idea what he was talking about. He goes, well, personally, I don't think you've ever been inside the box. And I go, okay. And I'm sitting there, is that a compliment, an insult, or both? Whatever. But he asked me to actually go out in the streets and see if there's a different way of looking at things. There's something we can do differently based on what you're seeing out there. So as we end this talk later, you'll see a couple examples of that as we get along through here. So a few years ago, I was living in the city of Seattle to show you my, let's say, reality testing. This is my apartment at 11 o'clock at night on June 21st, because it's so far up north in the latitudes that there's still sun setting right at 11 o'clock at night. And this is the view from my apartment. Oh, but you know how much this room cost me? It's a 2-bedroom apartment. You know how much it cost me at that time? $195 a month. Now it's going for, I heard, $195 a minute or something like that, so it's good. But anyway, so they put me to work. They put me on the streets with the Seattle Medic One program. We just started this thing called paramedics, which I thought meant there was a pair of medics out there, okay? And so I got out there with the two of them and started teaching them various things. And I developed a kind of a mentality of that the earlier the intervention, the better the results. And we're going to show you some examples of that as we get through here today. And the corollary to that, my mantra had become that an ounce of good pre-hospital care can save you a ton of ICU care. And can you give me an example of where that might be the case? CPR, okay. But will that save you a ton of ICU care? Possibly, that's it. Or there's a lot of other things. Or sometimes if you screw things up, you might. But I want to give you a good example in just a few minutes as we get through this, okay? So before I get started, I do want to talk about what are the 4 inevitabilities of life, right? Death, right? Taxes, what else? Kale, okay? And then, of course, disclosures, right? So here we go. So actually, the good news is I have nothing to disclose. I can get past that, right? Except that I'm not a morning person, okay? So that's the one thing, that kind of thing. But I just was remembering, I do have financial conflicts with this person almost every single day, okay? And and of course, she's we get past it, whatever. But she considered me her insignificant other. Do you guys know what this P06 is? When they have a scientific study, they want to know what the p-value is. And p.05 less than 0.05 means the chances of it being 1 in 20 or 1 in 100 that this could have happened just by chance. So I'm insignificant. She calls me her insignificant other when they said, are you going to bring your insignificant other? So there you go. Here we go. So before the main talk, I want to say that there are various technologies I will not talk about here today that are coming down the pike. For example, on the streets of New Jersey, they're looking at things like TEE, transesophageal echocardiogram. So, for example, you can see where your hand placement might be optimal, getting things out the aortic route. Because you can think about it, if you press in the wrong place, you might actually prevent flow out the aortic route or not make it as optimal as it could be. And maybe you can find where your hand position is gets the better flow out by doing that. So there's that kind of stuff that's happening out there. We, of course, are very familiar with all the AED stuff that's out there and the issues now where they can alert you and tell you where it is. This is a Reboa that's used for trauma, but it also can go up into the aortic arch and maybe help get better blood flow to the brain and heart during CPR as you lost vascular tone. And so that's one thing that's coming along the line. And then the other thing we've been taking to the streets is ECMO, and I've been out there on the streets in Paris, for example, and you can see it's even been used in the Louvre over there on the far right. That's why, by the way, I think it's why the Mona Lisa is smiling all the time, because there's good resuscitation work. The traffic is so bad there that they couldn't get to somebody and bring them back in time, so they're taking it to the streets there. It has to do with the new policy that one of the mayors put in there. So I've been out there doing this with them. It's fun. Even in places like Albuquerque, they're going to take a crank-based ECMO system out there. And so you may see this coming down the line, but I'm not going to get into it too much. But to tell you about the reason why we're going that direction is because some interesting work at the ED has really made a lot of things change. Dimitris Yiannopoulos looked at people with refractory VF, brought them in on Lucas devices with an ITD, and brought them in to the hospital, and they're getting back people that use what's refractory VF, where you couldn't get them out of VF. It's usually been very low survival chances, 4%, 5%, and they're pushing 44% now with this group, and it's been kind of exciting. 42% at 3 months normal. So it's been cool, and even one of my companions, Joe Ornato, who was a chairman of emergency medicine, who's also a cardiologist, ironically, over at the VCU, Virginia Commonwealth University. He was at home and all of a sudden got the sudden shortness of breath, and paramedics responded, came in, and I can tell you this story because he's talked about it publicly, so it's not a HIPAA violation. So the paramedics show up, and he's the medical director for the city. So he sort of says 3 words, just about 3 phrases. He goes, PE, VCU, ECMO, okay? And so the paramedic said, are you telling me this as my boss or as your friend? And he goes, it's your boss, okay? So I took him there. Within 7 minutes of hitting the door, went into cardiac arrest. He got an ECMO, and he's out and about and with us again, so it's kind of cool. So that's sure some futuristic things. I'm going to drill down on something we're going to be doing maybe within the year, within the year or 2. So I want to review the current focus on the quality of CPR and monitoring compressions and why it's so important to, and maybe even talk about something called the sweeter spot, okay? We'll analyze why we need both evidence-based medicine and experience-based medicine, and to be wary of certain fake news in resuscitation, because you guys are told one thing, then told another, and it's confusing, and there's reasons why it's confusing. So we'll discuss adjuncts to enhance flow versus pressure. Everybody's always been concerned about getting coronary perfusion pressure restored, and we're talking now about getting better flow out there. So we'll get through a couple of the topics, hopefully, as we get through. And talk that these are revolutionary ideas, and that doesn't mean necessarily some new major change. It may be we're coming full circle around the sun, and we're revolving, we've come full revolution to better CPR and better flow. All right, so let's move on here. A lot of what I'm going to talk about is deja vu all over again, but I'll make some new teaching points as we get through this. How you like that? You like my pants? Those are my mattress pants I used to wear, so that's cool. All right. I like this one. We're going to have to whip through it because, we have a lot of material to cover. I don't know if you know what this is. Like most veterinary students, Doreen breezes through Chapter 9. You know what Chapter 9 is? See, diagnosis and treatment, broken leg, infected eye. This is equine medicine, taking care of horses, right? So it says here, broken leg, infected eye, splayed hoof, treatment, shoot. So we're going to start breezing through. All right. A lot of the reasons why many of us are in this room is because the great dragon of death, ventricular fibrillation, was recognized in the 1950s and 60s. And so the idea of taking it to the streets to maybe bringing back people because the earlier the intervention, better results. Surprise, right? And so this dates me because I was back looking at this stuff. Anybody know what brand of the defibrillator this is? It's a 5. It is a 5. You got it. Nailed it. Okay. And the idea, it was the workhorse of the industry. So it was pretty straightforward. So we would come along, and it was not a disease of the elderly at that time. So I actually have a video of me doing one of my first defibrillations out there years ago in Stockholm, of all places, when one of my friends was getting a Nobel Prize. And so let me show you. There's my picture up there at that time. And see if I can play this. Here we go.
He's had a cardiac arrest.
Sì, ventricular fibrillation, I think.
Or tachycardia.
Ventricular fibrillation or tachycardia.
His heart is fluttering. There's no effective beat. It's hopeless unless we can get him to a hospital.
It's too late. No time.
I think he's failing.
You can't let that happen. Provvisare. Improvise.
Recoil's not so good on the CPR.
Lui non deve morire. He must live.
You must leave. Okay. Good. You got,
Open
that's where I get my
shit.
accent from, right?
It'll kill him.
Get back. Oh, don't touch him.
Don't touch it. Clear, right? That's where it came from. Gasp.
Where am I? Heaven?
Stockholm.
Ah, heaven.
We did it, forget it. We did it.
You did it.
So it was cool. And then we decided to go for it. And now, you know, we've come so far. There's even things like public access to defibrillation now, right? So here we go. These were one of the early days of public access defibrillation. Sometimes we forget about the technique of hitting it in the rear, so that's good. So anyways, we do have public access defibrillation, and this gives you a good example of when I was saying that an ounce of good pre-hospital care can save a ton of ICU care. In a study we did back in the late 1990s where we put these automated defibrillators in at the airport. The FDA was all over us about this one. It was kind of interesting, and they said, how can people get permission, you know, for, because they're dead. And I go, yeah, they're dead. I think they wouldn't mind at all. So it's an inferred, you know, so anyways, it was interesting. We got past it. USA Today medical writer helped us with that one, and then we put them out in the streets. Now at the airport, meaning in the terminal and gate areas, so back then at O'Hare Airport, I had just trained the Surgeon General and his staff, and they were saying, we got to get these things out there. The GAO said, can you have any proof of this? And I go, yeah, trust me, I'm a doctor. They go, we need more than that. We're the GAO. So I said, okay. So we went to the place where most cardiac arrests occur. Well, most of them occur in the home or whatever, but we're saying that there's a public place that more people are going through. It's not a particular hotel, it's the airport. So the 80 million people are going through there. So they have about a dozen cardiac arrests a year. And by the way, they're fresh ones in a sense because they're younger population and they tend to have ventricular fibrillation. And so in the first year alone, we had 9 cases that went down the ticket counter and gate areas where we put these things out there, okay? And so how many of those people do you think survived this in that first year, those 9 people? Anybody have any guesses, huh? 0 survivors? We had no survivors for the previous 3 decades. How about now? So you had said 0? Okay, any other? I got a 1. Any other bids? 9? You say 9? Well, what if I was to tell you that in 6 of the cases, the people had never seen an AED before and they'd never been trained in it, but they just heard about it. What do you think now? You should have stayed with the 9, okay? All 9 survived, okay, 100%. And the other thing that was really extraordinary about that, because they're so easy to use, and the other thing that's extraordinary about that is that almost everybody was waking up before traditional EMS arose. Those guys never even made it to the ICUs, which was the, right? Ounce of good pre-hospital care can save a ton of ICU care. Now, CPR is being performed and being performed well during that period because you're apt to get people around there, you know, in an airport, in a public area, you're more apt to get a better chance of surviving because there's going to be bound to be someone who might know how to do CPR or try to or whatever, or you feel empowered, like, should I put this thing on them and shock them, you know, and you go, yeah. So, but it's cool. So here's a good example of an ounce of good pre-hospital care can save a ton of ICU care. And almost everybody was shocked within 3 or 4 minutes. The other thing, though, was interesting is that the person who is leading the study for us, the paramedic that staffs the place, that set up the program, she was actually the first case, she was actually showing someone, well, here's the way the thing is placed. And she actually saw right there in front of her a guy collapse at the ticket counter. That was our first case. So the reason why I'm bringing this up is it's a 0 response time. She's there. It's right there. She pulls it. She goes there. But when do you think the first shock is delivered? It takes about a minute or minute and a half by the time you get there, turn the shirt down, and check in and whatever out and all that stuff. So especially if it's best if you have a couple of people, someone could be doing one thing while another person's putting the AED on. But when you collect, well, we got to shock them within 3 minutes or 4 minutes, keep in mind that it's not perfect, in terms of there's other things that have to take place before you actually deliver the shock, okay? So let's move on. So my mantra is an ounce of good for hospital care saves a ton of ICU care. Classic example right there, and I've got a few others. We're going to see some cool stuff today as well as we get through this. All right, what's next? What do I have on the agenda? So let's talk about the chest compression part, right? So chest compressions, even if you're going to shock these guys, chest compressions are really critical to getting them back, okay? And that's part of what the focus of today will be on a little bit, okay, as we go through this. This is good. I needed that really badly. Okay. So in the past, what we've done is we've looked at this thing of compressions, and what we found is we're doing this, we're building up kind of a pressure head, and then it kind of falls off, okay? And then we build up the pressure head and it falls off. In the old days, no wonder that we never, what's the survivorship for kids with cardiac arrest? What's your experience with that? What's the chance of them going home? Children with cardiac arrest. You're shaking your head. I mean, you don't know, or none of them go home. It's negligible, right? Okay. So one of the problems with that is that the way we did CPR with them is sort of along this thing. Remember that 5-in-1 thingy? Well, this looks like the thing to take the breath only takes about 2 seconds. You know how long it takes to give the, like, for example, in this scenario where you're doing the 30-2 thingy, you know how long it takes to do the things that look like it's only a couple seconds there? They actually measured people who were just trained, medical students, firefighters, 15, 16 seconds when it's optimal, okay? So the problem is you're not building up a good pressure head, then it just sort of falls off, and that's part of the deal. That's where this whole thing finally evolved in the 2000s, where they started talking about keeping your hands on the chest. So then we know what chest compression fraction is. So chest compression fraction is the amount of time you spend on the chest, let's say over a 5-minute period. And if you're stopping to check pulses, if you're stopping to intubate, if you're stopping to whatever, or just stopping to switch people off, it can interrupt the flows too much. And so this thing, they looked at chest compression in terms of survival, and the more time the medics or whomever spends time on the chest, the better the survival. So that's where we came with this thing, like try to keep the hands on the chest, and we even moved on to, what's that thing called? Compressions only CPR, which is not necessarily the best thing always, but there's a thing to minimally interrupt is really probably a really good point, et cetera, okay? So what happened in 2010? We started getting all this stuff in the early 2000s, and 2010, what did they tell you? What were the new guidelines? Because before that, what did we do, 100 to 80 or something like that? Or 80 to 100 in that ballpark? Then 2010, what did they tell you? Push hard, push fast, was that right? So we got to take a small commercial break here, I think. And, so we were being told push hard, push fast, and so here's a message from our sponsors.
With the new CPR Jackhammer. Now, you'll not only meet, but exceed the American Heart Association guidelines for compressions. After all, don't you think more is better? Deliver an average of 3,542 compressions per minute with the new CPR Jackhammer. CPR Jackhammer, because more is probably better.
Okay. So what do you think? You think that's the case? Did that work out? How did that work out, right? So maybe not. And here's the reason why. I'm going to give you an idea. We started looking at this. So you can see I'm actually one of the co-authors on that. Ahmed Idris, who's our research director, and some others, we decided to look at this range before and after we did the changes. And we looked at people getting 80 per minute, 90 per minute, whatever, up to whatever, 120, and said, okay, where was the best survival range, okay, in this area? So sure enough, we looked at this and we found a sweet spot. And what you see here up on the thing, I don't have a thing, but what you're looking at here is average chest compression rate. At the bottom, you can see it goes 75, 100, 125, 150. Yes, people are doing it as fast as 150. And then on the other side is percent surviving to discharge. And you could see it was gradually raising as you went from 75, et cetera, up to about 110. And then, boom, it just fell off, just like that. Do you know what the reason for that is? What we found was that when you're going so fast, you weren't going deep enough, and you didn't get good recoil. So you're actually worse off going faster, okay, than you were, say, at 80. But on the other hand, when people were going deep sometimes, deep enough, they were going too slow as well. So it turns out there was this sweet spot right about, 110. So you know how we fixed that in our system? We got a big piece of high-tech equipment. Anybody know what that was? Metronome, okay? So back in 2010, we went and got a metronome, and we put it on, and we got better survival rates, and we improved things tremendously. So we said, got to do that. Somebody else did a study on chest compression depth independently, and they found sort of similar things around, 4 to 6 or something in that ballpark. So they found these good ranges. So we were calling this the sweet spot of CPR. And that's kind of where we left off in 2011, 2012, something like that. All right. Now, around the same time, a study was performed about the impedance threshold device. Anybody know what that is? How does it work? You said yes. How does it work? Do you know? Huh? Yeah, it creates some negative intrathoracic pressure. So the way it works, the easiest way to think about this is, I'm sorry for those since I got on the floor here, but if you press on the chest like we're doing a turkey baster, and you release, it sucks things in. So what do you think when we squeeze, what do we suck into the chest? We're sucking air in, and we're also sucking blood into the chest. When your heart is beating like this, and we take a deep breath, we're kind of filling it up, and it's really, by taking a deep breath, we're actually bringing blood back into the chest because it's creating kind of a vacuum. When your diaphragm goes down, it goes like that, and it's sucking air in, it's sucking blood in. That becomes really important, for example, if you're exercising, because you got to pump more blood out, so you better suck more blood in, so you can go from 5 liters per minute up to 15 liters per minute that you're cranking out. But if you're breathing for somebody, it's a different story. You're giving positive pressure ventilation, and you're inhibiting blood flow. Well, anyways, during CPR, we're doing a squeeze on them. We release, okay? In theory, it pulls some blood and air in. But when the air rushes in, then it goes, you've neutralized the pressure, there's no more vacuum. But what if I was to cap the airway? So I crush in like this, cap the airway, I go, It's like you sucking through a straw. So you increase the vacuum of blood into the chest, and that's how it kind of works. But it's there for just a second. You go, okay, and then it goes in. Now, in the laboratory, this had great survival rates. I mean, impressive. I'm just sitting there looking at it do it. What do you think happened when we went and did a big clinical trial, a very elegant trial, NIH study, like 150 EMS agencies across the United States and Canada, okay? Elegant study, meaning everybody got an ITD. Half of them were inactivated and half were not, but we didn't know what it was. Had a code, they were all coded, and we could figure it out later. We broke the code later to figure out who got what, and we look amongst the survivors and all that. When we did that, we found that there was no advantage in survival from the ITD. And some of us were going, that's strange. It should have really worked. I wonder what happened here, okay? So, meanwhile, right about the same time, another study comes out with the ITD combined with a pump, an active compression decompression pump. And so if you don't know what that looks like, it looks something like this. It's almost like a toilet plunger kind of thing. It goes on the chest, and you're not only compressing, but you're also decompressing as well. So you're actually creating more of a vacuum. And I'll show you a picture. This is actually a video I took off my phone back in 2000, just to give you an idea, okay? And here's how it works. And you get the general idea now. So you're not only compressing, but you're decompressing. So this is another way of sucking blood into the chest, okay, as well. So when this thing came out, well, it turns out that the outcomes were dramatically better. For example, the improved long-term survival with favorable neurological outcome went up like 50%. This is a 49% improvement when you're a year out neurologically intact survival. Wow. So, how do you explain the discrepancy? Anybody know? What could be the possible explanations? Well, one could be that, that the ITD doesn't really do anything, and that it's just a passive thing during this event, and that the thing that really does it is this thing, okay? That's one possibility. Or the ITD works only if you got that thing there, right? But there were some of us who said, we did this study on the sweet spot. Could it be the quality of CPR that they were doing, okay? So we actually went and questioned that. We said, could it be the quality of CPR? So when we went back and looked at those people who got ITDs and who didn't at the different ranges within the sweet spot, look what happens. The blue is an active compression, the blue is an active ITD. This is the activated one. And the green level is the inactivated one. And so if you look at that, 99 to 99, 90 to 99, 100 to 190 to 109, 110 to 119, and look what happens right in the middle there. If the ITD is in that sweet spot, it does really well. If you're outside the sweet spot, it actually may be a little harmful. It's not as effective, but maybe even not on the right side of things. So as a result, what happened here is if you actually looked at the ones that are in the right zone, the ITD worked really tremendous well. Where it says MRS less than 3, that means with neurologically intact survival. So to achieve neurologically intact survival with the ITD, you really needed to be in the sweet spot. But you know what? The sweet spot only tells you about the rate. What about the depth? All right? So that led us to another paper we did, which was the quality of CPR was an important effect modifier in cardiac arrest. And we looked at everything like chest compression fraction, how long you had your hands on the chest. We looked at compression depth. We looked at rate. We looked at all those factors. And it's fascinating. What we found was that only about 20% of the people in the study out of 8,000 had gotten really good quality CPR, even using very liberal criteria, like a chest compression fraction of 50, I wouldn't consider adequate CPR, or rates of 80 to 120. We're using very liberal criteria, and it turns out only about 20% of people fit into that. So we said that the problem was that maybe there was a confounding factor, or what we call an important effect modifier in cardiac arrest intervention trials, and you need to be paying attention to this and make sure you're doing quality CPR. So I've just recently this has just been accepted in the Journal of the American Medical Association cardiology section, and a study where I looked at the sweeter spot. And what I'm doing here is looking at the ITD versus the sham ITD, and looking at it with, what's the word I'm looking for? At the different rates and depths. So let me tell you what you're looking at here. This is kind of like, it's called a contour plot. It's really cool. And I call this a sweeter spot. We're looking at what's the optimal combination, because if rate affects depth, or depth affects rate, what would be the optimal combination of rate and depth together? So what you're looking at, here we go. What you're looking at here is 60, 80, 100, 120. That's the rate. And here's depth over here, 4, 6, et cetera, centimeters. Okay, and this is with the sham ITD. That means that's just standard CPR. And over here, we're going to be looking at the ITD in a second. Now, what this blue stuff means is that there's 0 survival chances here. You get a little lightish blue here, it's getting better, okay? And that's up to like 3% survival neurologically intact. If you're in the green zone, you're getting 5, 6, 7% neurologically intact, and almost 8% with that little blip right there, about 4 point something and 110 in that area. So what's fascinating is that there is a sweeter spot we got to try to target, and it goes along with some of the stuff we heard before. Here's where it gets interesting. When you have the active ITD on, look what happens. It's the same kind of spot. This is around 4.7 and I think 107 is what we found. And you're in that area within a few seconds or a few chops or compressions and the depth rate and all that. If you're in this thing, your survival rates are over 11%, 12%. So you go over the top. So how do you translate this? If you are going to use an ITD, you got to be in the sweeter spot. And if you do, you'll get reward. You'll get your survival rate will double, if not more. And we sort of saw that previously. So that tells us that's cool. But either way, you want to do standard CPR well, and maybe in the future we need to be monitoring things online at the time we're doing it and that we should actually make sure that we're doing quality CPR in terms of rate and depth during that period of time, okay? So interesting stuff, and this is going to be published this month, so you'll be hearing more about this, and I think you're going to see people wanting to make sure they have monitors on board so they can make sure they're doing it. Oh, another thing you could do is use like a mechanical device that will deliver this stuff at that rate. And that's the other interesting thing. So that's going to bring us to, so maybe the thing was not a neutral trial after all. Maybe our experience told us that something's wrong here, and we did this other thing on quality of CPR, maybe that's a factor. Or when I look at these studies about epinephrine, or I look at this study about whatever it may be, pediatric intubation, no one was accounting for positive pressure ventilations. If you're overzealously ventilating someone with positive pressure, then they're not going to get any blood flow back into the chest at all. So there's a lot of things that are not accounted for in these studies, and that's part of the problem, these confounding variables. And that's why you may get confused. So Tom Aufderheide, who has been the lead on several large studies like this, and I were at the National Academies of Science, and we presented this thing, we called it, when we published a paper called EBM versus EBM, that you need to have both experience-based medicine, let alone evidence-based medicine. Because sometimes the stuff that we're told in evidence, you know, like that thing about the ITD didn't work, but it was an elegant study. It was perfect. It was NIH, it was New England Journal of Medicine. It was elegantly designed, and yet there were things missing there. Okay, so we ultimately said what you need to do is that research has to be spelt better. It should be RE dash. We have to continue to research these things, and that's why you get conflicting reports all the time. The problem is, if I told you about a study at the airport in Chicago, and that the report I just gave you, if you had someone else say, well, I want to repeat your study, and they came back and said, oh, we didn't find any difference. We had every other day we used an AED every other day. And we did over 2 years, so it was pretty even groups and all that. And they said everything was well matched, but we didn't find any difference. I go, really? Yeah, it says, and they said, yep, the ages were the same, the number of people with VF, just everything was exactly the same. Well, then I'd say, but when was the first shock delivered? They go, again, evenly matched, 10.2 minutes versus 10.4 minutes. I go, you didn't give a shock for 10 minutes? So that study would be considered accurate if you don't deliver the shock until 10 minutes, but it doesn't mean the AED doesn't work. So when I hear people say the ITD doesn't work, or the AED doesn't work, or whatever it is doesn't work, TXA, it also depends upon the timing. It may depend on how you're using it, the quality of CPR, for example, as we saw here before. So things are not good. It's not an absolute that it's good or bad. It depends. It depends how you're using it, okay? So I'm going to play you something Star Wars I like.
If you're not with me,
People get,
then you're my enemy.
you're my enemy if you're not with me on the ITD or whatever.
Only a Sith deals in absolutes.
So only a Sith deals in absolutes, and that's my point. And so that's why I basically tend to do research, and that's my job, which is to sort of quickly find out what needs to be done and what's the things we have to look at next, et cetera, and maybe define why there were conflicting evidence and why there is discrepancies out there. And this helps us understand that a little bit better. So that was kind of old hat, right? Want to go into anything new? Okay. What else is there? Okay. Oh God, he's been doing this to me for the last 3 talks. Okay, he got me in. He got me in New Mexico last week too. Okay, all right. Okay, got it. Here we go. Okay, so gravity assisted. Guy's always hacking into my slideshows. So gravity assisted CPR. Okay. So what's that about? Why did we come up with this? So that's part of the reason like we want you out in the streets to see if there's anything new we can do. So you're hauling people up and down stairwells all the time, right? What if you're doing CPR? Which should we do? Should we put the head up? Should we put the head down? What do you think? What would be the right thing to do here? Well, one thought is that if you put the feet down and you got them under the armpits, that might be a good way they don't slide maybe or something like that. But what if it's not the best thing for blood flow? What about Trendelenburg? Should we do that? Should we put them in Trendelenburg to get better flow? What do you think about that? Anybody have any opinion? Well, you just don't know the answer, right? You want to just check it out? Yes, go ahead. More perfusion to the brain if you put the head down, you're saying? Okay, so that's sort of the standard thinking that people have. Here's the problem. I'm here, right? What happens when I'm here? I take you to the existential fun park, okay? And in the existential fun park, It's always, why are you here? It's like I have to ask myself that every single day, okay? Why am I here? I'm here because I will tell you, don't believe everything you think, okay? Or you've been taught, right? So here's the reason why. The potential flaws of supine CPR is what? What could be a possible flaw? It saves lives. Why would it be flawed? How could it be flawed? Well, here's the deal. When you're doing supine chest compression, what you're doing is you're pressing on the chest, and what's happening to pressure? Pressure waves are going up both the arterial side and the venous side, correct? So you're actually sending pressure waves both ways. And so that hits up in the brain, you increase intracranial pressure. Now, that flow in the artery kind of wins out, but it's not optimal. You follow that? So you're increasing intracranial pressure, and so the flow through the brain is not so optimal. And the same thing for the heart or the rest of the body, et cetera, right? So it increases both arterial and venous pressure in the brain particularly, let alone the rest of the body. So we have been doing work in laboratory, and this is Johanna Moore, who's been leading our team in the lab. And we're looking at this concept of what do we put the head up or head down? What would happen when you do CPR? Does it improve flow? Does it improve cerebral perfusion pressure? How does that work? So we're going to be looking at the supine versus the head up. Now, why would I be putting the head up? Well, what if I put the head up? We learn this from neurosurgeons and sometimes what we do is we actually drain blood out of the head. Would we give an advantage by doing that? Maybe. We'll see. That's the thought. That's the thinking process. So look at this. Supine CPR on the left, that's aortic pressure, intracranial pressure, and cerebral perfusion pressure. And when I push it down like this, boom, 30 degrees head up, look what happens to intracranial pressure. That's not too bad. That's a major decrease in intracranial pressure. So what do you think is going to happen to cerebral perfusion pressure? So cerebral perfusion pressure goes ways up. This doesn't look too bad, but it's the scale. And you're talking about going from 75 to 100 here. Let's see, 75 to 100. It's a major improvement in flow. In fact, we've looked at blood-brain flow, and we get much better improvements. This is what I call gravity CPR, aggravated CPR, gravity aggravated CPR. If you think about yourself on a monkey bars, you could feel your head filling up with water, blood as a kid. It's the same kind of thing under those circumstances. We put the feet up. Look what happens here, okay? Boom. Aortic pressure stays good, and cerebral perfusion pressure goes way down. So by the way, this is at 30 degrees in the animal models we're using, okay? So why don't I pick 10 degrees or 20 degrees or 40 degrees? And it turns out that the head up, like in the 40, you start losing aortic pressure. But 30 is probably a thing we could get away with in the animal models so far under those circumstances. And so that's the reason why it's not something just arbitrary that we picked, okay? Turns out in humans it may be a little bit better at 20. They have different kinds of legs and things like that. So how about brain blood flow? You betcha, same thing. Minus 30 versus 0 versus plus 30, much better flow there. It's all the same thing. So head-up CPR. Now, here's the problem. Remember when I showed you that we had the model was this, I showed a kind of a model instead of the animal, but you saw that there was a couple things attached to that model. There was there was that Lucas device, also an ITD was the thing. And what I'm going to assert to you, the question is, do you need those? Is the head-up alone really a good thing, or do you need those things, right? Does the head-up still work without the ITD and ACD devices? So we actually started doing some work. Here's a study I presented at ACEP, the American College of Emergency Physicians, last year, in which we looked at coronary perfusion pressure and cerebral perfusion pressure. As you see here, we go from 0 supine position up to Lucas and ITD. You're getting much better flow there. And if you take the ITD off, then it goes down. So you needed the combination of the two, plus it sort of goes along with what we saw in those other clinical studies. Now here's the more interesting study, I think, right here. This is the money slide in a lot of ways. I'm going to look at the center screen for those, I don't know if you can see it or not, but just going to point at the center screen. This is the cerebral perfusion pressure starting at a normal animal. And then this goes on, they get shocked, their pressure goes down, and then now we're doing CPR over 20 minutes. Here's minute 2, minute 7, 12, et cetera, on out to 20 minutes. So that's 20 minutes of CPR. Look what happens to supine CPR. You get some pressure there, but then it starts falling off. Why do you think it falls off? Anybody know? Say again? Could be, but this is a situation where we're using the machine, okay? So it basically is not particular, yeah. But here's the reason why, is that cardiac arrest is not a static process that's dynamic. It means, like, for example, right now you have a coronary perfusion pressure because you have peripheral vascular tone. Right now you have some tone, it means little muscles, little constriction in your blood vessels. And if you get into a hot tub or you get overheated, they're going to expand, they're going to dilate. So if there's no oxygen going out there to the tissues, what do you think is going to happen to your blood flow? They're going to dilate, and things are not going to be so good. It's like sort of doing CPR. And that's the reason why we can get a really good heartbeat on somebody with the epinephrine, and then they're pumping for a while, and then what happens is they haven't had enough oxygen in the tissues. They're all peripherally dilated out there because they haven't had oxygen go there for a while. And if we don't keep things going, they will crash again because they're really going down. So that's what's happening there. They're basically losing their vascular tone, and the CPR is not effective. The next thing you look up on this thing here is what? It's the green thingy. And in the green thingy, that's the head up. And the head up is much better than the supine alone. But guess what? It starts falling off as well. However, if you put the ITD and the active compression decompression pump on here, as you can see, it not only is better, but it actually sustains it for a longer period of time without falling off. So it's kind of a more optimal situation, and you don't crash as fast, and that's it. But guess what? What do you think the top one is? The top one is active compression, decompression, ITD, and head-up CPR. You put them all together, and that's not even additive. It's synergistic, and it sustains it. Look at this. It doesn't fall off. So in the laboratory, we're finding these striking findings with head up and shoulders up. And later we found out that Trendelenburg is probably not the way to go. It probably is that the head up and chest up is much better to do. And we've been learning that over the last couple of years as we've gone through this. Okay? So we actually looked at whether you should do Trendelenburg or reverse Trendelenburg is in this case, right? And then later looked at head up alone or head up, and it turns out that you get lower pulmonary vascular resistance if you have the chest up a little bit as well. And it's kind of like a CHFer who wants to sit up. They get better flow through there, so we think that's what's going on during this period of time. Either way, they do much better with C, which is a kind of head up and chest up configuration, right? So we've been learning this in the interim. Okay, so what about survival? Well, I was giving this presentation in 2015 at the Gathering of Eagles, where my job was to talk about what we were doing in the laboratory, because we're just working on it in the laboratory at this point, nothing to do with humans. And I'm showing this same slide. There's my same bald head, looking at the slide. And guess what? These guys come up to me and say, "We want to do this." And I go, "Didn't you hear my talk?" I said, "Do not get into this yet." He said, "Yeah, but we want to do it." And I said, "Well, you can't. It's not ready for prime time. Maybe I should have done that Men in Black thing where I take the little flash and make you forget what I just taught you." And he goes, "Well," he said, we got to work out all this stuff. It could be harmful if you do it too soon. We're thinking that you got to wait a couple of minutes, then you start elevating slowly." He goes, "Well, we'll do it." And I said, "Okay, we haven't even done feasibility studies." He goes, "Well, we'll do it." And I go, "Look, you'd have to have an AED and a Lucas device in every truck, that kind of thing." And they said, "We got them." I go, "Really?" Okay, so the next thing you know is I call up my compadres at the lab and say, "Hey, why not?" So we go ahead and do that, and this is roughly what they did. They used a Pelican kit to sort of do this thing, and they just improvised it. And this was in March of 2015. I gave the talk in February. I went down and gave them some direction about what to do this. And look what happens. During 2014, the resuscitation rates, everybody put together, cardiac arrest for asystole presentation, VFib presentations, PEA, whatever it is. Across the board, the outcomes were there in that range and steady and all that in January. February, I gave the talk. March, we start implementing this, going from station to station. And we finished almost everybody about May, end of May, something like that, June. Look what happened. Is amazing, okay? And it was striking. I'm the first person to go against what they call historical controls, what we did before and we do after, because other things could have changed. Nothing else changed in this period. It was like really impressive. They were already using the ITD and the active compression. And this is what makes me think that this thing, that slide I showed you, was important, because I don't think it's additive, I think it's synergistic. These are all different mechanisms to get blood out of the brain and into the chest. So you put the ITD in, it's the increased intrathoracic pressure, so you're pulling more blood out of the brain into the chest. You put the pump on, you're creating a vacuum. They're all different mechanisms. Head up, all different mechanisms, but they're enhancing blood out of the chest and into out of the brain and into the chest. So it's been kind of cool. So this is a paper I just published about 2 months ago. And what you see on the left is the 2014, and you can see we looked at quarterly resuscitation rates, and it was about 18% before the transition. And this is a range that you have there of about 14% to 20%. So this is the image standard deviations, and then all of a sudden we do this, and boom, you can see the transition period in quarter 2 to 2015. And now we're getting rates that are way up there at 33, 34%, or I guess, yeah, 34, 35%. And it's just profoundly different. It just was striking is what it is. So anyways, the other thing that was so cool, and this is just the first couple years alone, because 2015 was a transition year, and look what happened was that the number of patients that got resuscitated by EMS went up to 221, and so now that's going up further, but we're doing other things, the dispatch center and some other areas, okay? So that's just been published. If you want to look it up, someone said, hey, I want to get that paper. I said, go to Google. And I said, okay. Go to Google and put Pepe, P-E-P-E, put Crit Care Med, which is the name of the journal there, okay, Critical Care Medicine. So Crit Care Med, and then put confirming, and boom, it'll pull it up if you want this, all right? And it is now considered one of the most popular articles out there on the net. You can see it's Critical Care Medicine 47, March 2019, okay? All right, so the conclusion on the head-up stuff so far is that it likely works, it likely improves neuro outcome, and it depends on enhanced CPR for it to work. And both head-up and chest-up is better. And lowering ICP may be a new focus for us in this whole arena. Not ready for prime time yet, though, okay? We are really concerned because in some studies, if you just put the head up and do it right away, the outcomes are probably worse. You've got to kind of prime the pump first. So sometimes when I go around and give this talk, I say, I'm not here to convince you to do head-up CPR. I'm here to convince you not to do head-up CPR until we get it right, until we have the right materials and do all this stuff. So what our next phase is that we're looking at this thing, which you already saw how it acted, because this has a better recoil. So could this work better than, say, the Lucas device? And I'm thinking it probably will, okay? And there is a new device, I think, I don't even know the name of the company, in which this was a prototype that we used in the laboratory in which you can attach this thing, and then what it will do is after about 2 or 3 minutes of the cardiac arrest, it'll start elevating you slowly over about 2 or 3 minutes, et cetera. And we've been using that, and we got some amazing results. I think this is the new version of it. Someone sent me the picture. I thought I put it in. I have no idea, again, what the company is. But this is us looking at the laboratory a couple months ago, and I'm just going to skip that because what happens here, as you can see, this is like the thing I showed you before, standard CPR at the bottom, active compression, ITD, supine, but you use this thing, I guess it's called L-guard or something like that, and you raise up the thing, and look at that. Not only after the 2-minute rides do they get these better flows, but what's really fascinating is that it continues to improve. They're getting near normal perfusion, from what I understand now, using that thing, because I haven't been up there with the new device yet, because I haven't been up to the lab for about 2 months, going back in June, and we're going to continue, but they're just going ahead with the studies. We're actually going to start using this in humans here pretty soon, just to see how this works in Palm Beach, so things are going along pretty well. So what I'm thinking that in the future, this is a synergistic bundle, that it may actually work better because we're lumping all this stuff together and we're controlling for ventilation, we're controlling for CPR quality and all those kinds of things. But a synergistic bundle is not necessarily a new paradigm. You think it's a new paradigm? Give me another synergistic bundle that's out there. Anybody know? What would you call the chain of survival, for example, right? Because when we came up with that thing, we were saying that the survival rate's not going to improve unless you got a good dispatch system, unless you got good quality of CPR, unless you got, all the other stuff intact. So you got to have all those to optimize your chances. And so it's not really a new concept for you guys at all. And so maybe on the year to 2020 that we could this stuff is actually available now. You can make it happen, but you got to do it right. And you could get people we never got back. So lastly, one more thing. Okay, everybody following this so far? Is this kind of interesting stuff? Okay, I don't know if it is or not because I don't want to bore you either. I can quit right now if you like. Okay, Ray, this is one, you were telling me that the survival rates for children is pretty negligible, right? So why is that? Well, say again? Yeah, so it's a respiratory thing, so then they go into cardiac arrest, so they're already behind the 8 ball by the time they go into cardiac arrest, okay? Whereas the VF person is full of oxygen, goes in the rest, we get there quick enough, they're probably not, that far down the hypoxemic chain. So that's one of the reasons why. The conventional wisdom about pediatric out-of-hospital cardiac arrest, as I call it, POCA, okay, is that they just don't do very well at all. So the focus on-scene care is what we were beginning to do, because this guy over here, up the top, is Paul Banerjee. He is the medical director for Polk County, Florida, of all places. This is the Polk County POCA, is what I call it. So Paul said, you have these great survival rates. How are you doing it? And I said, well, you'd have to be pretty disciplined. You have to do something completely different. He said, what's that? Because you'd have to work them right on the scene. What's the issue nowadays? What's the typical thing that people do with kids? Yeah, scoop and run, right? So why is that? Because you get to the scene, is it a pleasant, calm scene? Nah, right? It's total panic, pandemonium, volatile, crazy. Family saying, get him to the hospital, or whatever. That's number one. Number two is that everybody's a little intimidated about kids getting the IVs in. We don't do it all the time, so that's a problem. And then thirdly is that they're easy to pick up, so let's at least get them out of the scene, take them down to the ambulance. So that's understandable. It's what we've been doing. But here's the deal. Is that the smartest move physiologically? Are they already behind the 8 ball, and every second we waste could be worse? So I said, you got to work them on the scene and go right to an IO. Here's how you should do the IO, by the way. Get the IV in, get the drug, flush it in a little bit, and then stop CPR, then really flush it in, and then go right back to CPR, because it's got to go down to the head and chest, etc. It won't be as far a travel as an adult, and you can pick them up. Then the next thing you got to do, okay, is get them intubated. And the problem in the past is that people didn't have high skills, so we got a good group of people, small group, a cadre of people who are highly skilled, who we went through intubation after intubation and took them to sim labs with high fidelity mannequins with anterior cords. It got them good at this. And then we said, here's the problem. Once you get the tube in, what does everybody do? It's a respiratory problem. So what do? They go, which is absolutely the worst thing you could do, because it knocks out cardiac output. If you can inflate the lungs with a good breath, that's fine. You'll get them oxygenated that way with supplemental oxygen. And then, after you do that, you only have to give them breath one every 10 seconds, because it's a low flow state. So there's no oxygen going out to the tissues. So there's no CO2 being consumed to be brought back to get rid of. So just get the lungs adequately inflated by a big, good breath, raise the chest, but don't do it too fast. So here's what happened. We focused on-scene care. We controlled for ventilation. We only gave like 5 breaths per minute, okay? And look what happens. No survivors for several years, but I'm just using 2012 and 2013 as for a 2-year comparison to 2-year, but we had no survivors before that. Look what happens. We go up to 23% going home neurologically intact after the training protocol, et cetera, all right? So again, it's a historical control, but the historical control was to make a difference, whether it's the training or whatever, and say, hey, we can get kids back. That was the point. Now, here's the interesting thing. As we're doing this, I'm going, there's one other thing we can do here. What's that? Well, if I'm going to a scene and I hear it's a 9-year-old, what is the first thing I'm going to do drug-wise? I'm going to get some epi out, right? Because it's epi and oxygenation, epi airway, because all these kids are in asystole, by the way, right? So I'm going to get epi out. So a 9-year-old, how much am I going to give? That's easy, 0.5. 1-year-old, 0.1. We know exactly what it is. It's system 1 thinking. We know exactly. You don't have to go calculate this stuff. We know. And so what if I give a 2-year-old 0.3 or something? It's not that big a deal. But you got it, 0.1. If you're up to 4 years old, maybe 0.2, whatever. And then you get up there. So here's the thing. So that paper was just published back in February in the first 2 years, and now we've moved into the 3rd year. And what we kind of said after that, has anybody seen this thing here? I want to see if I can play this. Okay. So the kids that we used to think kids were dead, but here's what we think now after that paper we just put out. It was kind of cool because this is being shown around in journal clubs around the country. And we're getting people interested in maybe we can save these kids after all. So here we go.
Daddy can't talk.
Look who knows so much, huh? Well, it just so happens that your friend here is only mostly dead. There's a big difference between mostly dead and all dead. Please open his mouth. Now, mostly dead is slightly alive.
All right.
Daddy can't talk.
So we went on and did system one thinking, get the drugs prepared en route. So here's the deal that happened there. Look what happens now. Survival rates are going up to 35%. And by the way, we're pushing 40% now, neurologically intact. And here's the interesting thing. When in the old days, we used to scoop and run, get an IV later, or whatever it might be, or even an IO, it was 16.5 minutes when the first dose of Epi got on board from the time you arrived. When you basically started working them on the scene, we got it up down to 7.3 when the first dose hit from the time we arrived on the scene. And look what happens as we're preparing it around. We got it down to 5 minutes, and that's probably part of what happened here. We were improving it even further. So amazing stuff. So Epi could work after all if you give it quick enough, and that's part of the issue here, right? So I always have to show this one because it's fun. Pulp Fiction, right?
3.
I like when he says, say something.
You're all right. And say something.
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 That was trippy.
Yeah, it was. So anyways, the overall conclusion is that on the road to the 22nd century, hopefully we'll see that the dead shall be raised and we'll make life better for future generations as we go through this. Wrong one. Okay, here we go. Future generations, here we go. So with that, I'm going to leave you with one thought, and I will improve this is why I've been improving my English lately. Here we go.
Das hier ist mein Sektor. Das hier ist das wichtigste Gerät des Küstenwächters. Das Gerät und das Gerät. Überlebensradar.
Mayday, mayday. Hello, can you hear us? Can you hear us? Can you... Over. We are sinking. We are sinking.
Hello? This is the German Coast Guard.
We are sinking. We're sinking.
What are you thinking about?
Das hier ist...
All right. Well, I'm Paul Pepe, and I approve this message. Danke. Okay. Paul, do you want me to take any questions or just let it go? Okay. Anybody have any questions for me? Burning question? Yes, sir.
Fusion with CPR, and I kind of wonder about, you talked about not having any rescue breaths because you take the hands off the heart and it decreases the perfusion, and over time, even though people could survive at a pulse ox of 82% or something like that.
Yeah.
Is that still going forward?
Yeah, I was actually at my pulse ox was like at about 70% was on the top of Mount Kilimanjaro, and maybe you can blame why I'm so crazy on that. I don't know. But no, but seriously, is that I'm not all for necessarily not giving any breaths, okay? I was mostly giving the rationale for why we were going to no compressions, and that you got to avoid the absolutely high frequency rates that people tend to give, especially with kids. They're just this thing. Let's just do it. It's there. So that's the main caveat, is that, so we weren't saying don't give no breaths, we just said low number of breaths, but give a good lung inflation, because we also want the blood to pump through the lungs, and if the lung zones are closing off, then there's pulmonary vascular resistance and it's not flowing as well. So you got to create a good lung inflation, but don't overzealously give them positive pressure ventilation, and that's what happens with kids, let alone the adults. Okay, does that answer the question then? Do you understand the difference there? Okay, anybody else? Yes, sir.
With the hands, with compression only.
Yes, compressions only.
When you're doing it correctly, aren't you creating a vacuum and getting oxygen into them?
Yes. In a sense, you are creating kind of a recoil phenomenon where you're pulling things in. The problem is it's not effective. It's not that effective. and especially if there's a good pressure head already because nothing's moving. There's nothing pumping the blood out. So it just doesn't work as well. And studies have been done to look at that, and it just doesn't create enough ventilation, and you're not inflating the lungs enough. When you and I are breathing, we're pulling the lungs open in a very specific architecture down here. Your diaphragms are these dome-shaped muscles. They contract, and they pull the lung open like a syringe. You're going, right? You're pulling the air in, and you're pulling these dependent lung zones open, and particularly when you're exercising, you're going, you're pulling all the lungs open so everything is well oxygenated. So you'd be more like at 100% saturated, not 97% saturated, because some of those zones are not opened up. So that's what's happening there. When you're breathing for somebody, though, here, or if you give a breath, the air does not distribute there, and this thing is just not enough to get air in there and create. It's not pulling the lungs down, is what I'm getting at. So it's not as effective a system. It does something. But that's why we think putting this thing on board helps to enhance that whole effect a little bit better. Does that answer your question, you think? Good. Okay. Anybody else? Okay. Has this been okay so far? Okay, good.
In adult cardiac arrest, we've been leaning towards delaying epi and giving lower doses of epi. But when you were just talking about the pediatric arrest, you're saying prompt epi is more what we want to get to. Why the difference?
Well, because only the Sith deal in absolutes, right? And it goes back to the thing where I told you before, is that don't give the ITD, it doesn't work, or whatever. It has to do with the studies that have been done. When was the first dose of epinephrine given to the adults? Do you have any idea? That's the problem. No one tells you that stuff. Or did they account for ventilation? Nope. They never gave us any of that stuff. So a lot of times you're talking about 20 minutes for the first dose of epinephrine. I don't think anything's going to work out at that level. So people backed off. And then they associate things with worse outcomes, but that's because the people who get the epi, for the more epi they get, are already dead, and they're going to get more epi. So it correlates with that. And it's unfortunate, it's not a yes or no matter. So I don't know the absolute answer in adults, but I can tell you that to say that one should equal the other is not a thing, especially if the studies aren't done quite right. So, the high-dose epi study that was done way back in the 80s, actually, there was an improved neurological outcome using the stuff we use today, but the guys at the Heart Association talked the investigators out of using neurologically intact survival because they thought that the MRS thing or the CPC 1 and 2 were too subjective, but it wasn't. You're pretty normal versus a person who can't do anything for themselves at a CPC 3. So that could have been an interesting study there. That's all I can say. And that study was befuddled a little bit because in most of the systems, they were not controlling for ventilation, but in the one system where the ventilation was controlled, they had tremendously better outcomes, and they got the drug on board rapidly using the same techniques we just showed you with the children. Okay. Yes?
I think this is partially observation as well as a question. I seem to remember back in the 80s a story about a woman who was so frantic about her husband in cardiac arrest. She took a plumber's helper to his chest to do CPR, and that was the
San Francisco, 1991, 92, and that's where that idea came from.
Yeah, and it caused a big buzz at that time, and then all of a sudden, it suddenly fell off. It just fell off the radar there, and suddenly
why?
It's back again.
You know why? FDA. And the FDA was being under pressure because there was a senator saying we were experimenting on people at that time. And so that caused a big problem. That's where the so-called ethic, that is exception for informed consent ruling of the FDA, eventually came out several years later. But that just held that up. They did take the active compression decompression pump to Europe, and they did an impressive trial over there where they had even asystole patients surviving. So, but it just never caught on in the United States because we couldn't do any studies here, and people weren't up to it based on the original stuff. So that's the explanation there. But now it's FDA approved, by the way, which is really interesting. Yep. Anything else? Was this interesting for you guys then? Is this okay? So okay, good. Okay. I guess that's